maybe in the Telangana. Okay. Anyway,
I agree, but separated. No?
anyway,
Please
it's
continue.
really gives me a lot of pleasure to see my friend's face also. Subbu is a very close friend of mine because Subbu knows what's the reason. I know what's the reason. Okay. Anyway, so I wanted to congratulate our Andhra team for arranging such a wonderful and fabulous academy program for students. Not only for students, this will be definitely useful for our teaching faculty, non-teaching faculty, practitioners, GPs, physicians. My dear friends, this acromegaly, even though it's an uncommon situation, general practice, we have, especially you go to Andhra Medical College or any medical college for that matter, you can see good number of acromegaly cases. But I feel, see, the classical or proper approach is essential for clinching the diagnosis, for proper management of acromegaly case also. Recently, we got a reference from one of the practitioner physician, put it as a acromegaly, but it was not acromegaly. There are differential diagnosis for a student. Is probably is not that easy, but still is possible. So what I want to tell you that for an academician, for a clinician, proper history, proper examination, proper biochemical evaluation, cleans the biochemical diagnosis of hypersomatic tropism, then you go for imaging. And I wanted to recapitulate whatever discussed by Dr. Ameya. See, there are certain textbooks which gives lot of informations. Like, so one is our society practical management guidelines are available. And in addition to that, I want to recommend certain other textbooks of endocrinology, which is really useful for our practicing doctors and students. And I hope everything will be fine and you'll get definitely benefited. I wanted to congratulate the team again and again, and may God bless you. All the best for the academic activities. Thank you once again for inviting me as a guest of honor. Thank you so much, Subbu. Again, special thanks to our Subbu Bhai. Okay.
Thank you
Yeah.
for being there in your busy schedule. Thank you.
Yeah. Okay. Thank you.
So,
What, sir?
thank you, Jabbar sir. So now I invite Dr. Manohar to present the case.
Good evening, respected professors, respected Dr. P.K. Jabbar sir, Dr. K.A.V. Subramaniam sir, Dr. Ameya Joshi sir, and Dr. Vivek sir. Thank you for the opportunity. Am I audible, sir? Shall I share the screen now?
Yes.
Sir, is it visible, sir? Slides are visible?
No. No, it's taking time. Just see. Vivek, visible? Manohar, try again.
Yes, sir. Yes, sir. Please.
మనోహర్ ఏంటి ఇబ్బంది ఏంటి?
Stop sharing and try again. Again, stop sharing nokki, malla try check.
మనోహర్ ఏంటి ఇబ్బంది ఏంటి అవుతుంది?
Sir, nothing, sir.
Manohar, connect to Wi-Fi, not to your.
Yes, sir. Yes, sir. Yes, sir.
Yeah. Good.
Sir, is it visible now, sir?
Yeah, go to full screen. Go to full screen. Yeah,
Yeah.
perfect.
Yes, sir. Thank you, sir. We had a 45-year-old female who is a housewife and resident of Visakhapatnam who came with the chief complaints of joint pain from 5 years, protrusion of the jaw from 5 years, headache from 3 years, and irregular menstrual cycles from 4 months. Patient was apparently normal 5 years ago, developed insidious onset progressive joint pains from 5 years, predominantly involving the both knee joints, aggravating on activity and relieving with rest and medication. There is no history of any swelling or restriction of movement of the joints. It is also associated with hip and shoulder pains from last 3 years. There is history of protrusion of jaw from 5 years, which is insidious in onset, symmetrical, progressive, initially noticed by the relatives. It is associated with coarsening of facial features, associated with acne predominantly on the face and back, associated with oily skin and excessive sweating. There is no history of pain or difficulty in chewing. There is no history of any unwanted hair or hair loss. There is history of headache from the last 3 years, which is insidious in onset, intermittent, holocranial, aggravating with activity and relieving with medication. It is not associated with nausea, vomiting, or early morning worsening of the headache. It is not associated with blurring of vision or double vision or bumping into objects. There is history of menstrual irregularities from last 6 months. There is reduced in the form of reduced frequency of menses with menstrual cycles of only just for 3 days for every 45 to 50 days and needing to change 1 to 2 pads per day. It is not associated with any dysmenorrhea or abnormal uterine bleeding, not associated with hot flashes, not associated with milky nipple discharge. There is a deepening of voice from last 4 months, which is insidious onset and progressive, associated with snoring, disturbed sleep, excessive daytime sleepiness. There is no history of any shortness of breath on exertion or polyuria, polydipsia, tingling paresthesias, or difficulty in walking or difficulty in gripping objects or lifting weights. There is no history of any admission for uncontrolled blood pressure or increased blood sugar levels. There is no history of any postural dizziness or weakness of limbs or weight loss. There is no history of any neck swelling or lethargy or constipation, cold intolerance, or weight gain. Patient is a known hypertensive from 7 years, and she's telling it is fairly controlled with amlodipine 10 mg once daily. There is no past history of any kidney stones or fractures, peptic ulcer disease, any surgeries, any diabetes or hypothyroid or tuberculosis, epilepsy, and asthma. And there is no history of any similar complaints in the family. Coming to the summary, a 48-year-old female presented with progressive knee joint pains from 5 years, with progressive enlargement of jaw with coarsening of facial features, with acne, oily skin, excessive sweating, and intermittent headache from 3 years and oligomenorrhea from 6 months. associated with deepening of voice from 4 months with snoring and excessive daytime sleepiness. Patient is a known hypertensive with fair control. Sir? Patient is a known hypertensive from 7 years with fair control with amlodipine 10 mg once daily. And there are no features suggestive of any raised ICT or compression. There are no features suggestive of hypothyroidism or adrenal insufficiency, and there is no significant past or family history. With this summary, my differential diagnosis, first one is most probably an acromegaly, which could be secondary to pituitary macroadenoma, and acromegaly is active disease with hypogonadism and obstructive sleep apnea. Second differential diagnosis is hypothyroidism, even though it could be less likely with this presentation. Coming to general examination.
Dr. Manohar, maybe we can have some points discussed here.
Yes, sir. Yes, sir.
Yeah. Did you not think of any other differential diagnosis beyond acromegaly and hypothyroidism? And what are the points that are there in this case that are against hypothyroidism?
Against hypothyroidism, there is no history of any weight gain, lethargy, constipation, and even only the oligomenorrhea can be suggestive of hypothyroidism in this particular patient, sir. And also, oily skin is somewhat against the hypothyroidism. Usually, they present with dry skin and all.
I mean, if you have to tell me the strongest points in opposition to hypothyroidism, will you name these as your strongest points that oppose hypothyroidism as a differential in this case?
Yes, sir. And also, there is no neck swelling.
I
So-
mean, how commonly will you see, and what degree of hypothyroidism will, I mean, will cause this degree of symptomatology?
So only our hypothyroid can cause these symptoms.
Yeah, and then how frequently will you note headache and joint pains in hypothyroidism?
Uh, Uncommon with hypothyroidism, sir.
So, I mean, that is what you are, I mean, studying endocrine, or you have
Uh,
completed your DM?
No, sir, I'm studying endocrinology. Yes, sir.
Yeah, so when you are putting it as a differential, I think
Sir.
the most important differential point should be the first ones. Maybe you will not have headache, you will not have I mean other symptoms like you can have joint pains and hypothyroidism, but that usually is vitamin D deficiency or connective tissue disease. How
Yes,
will
sir.
the face look in hypothyroidism, and what will be common, what will be uncommon in the face in acromegaly and hypothyroidism?
Usually, facial puffiness can be seen with hypothyroidism, sir, not the coarse. Whereas in acromegaly, it is the protrusion of the jaw prognatism and prominent supraorbital ridges, nasolabial folds. These are more common with acromegaly.
Yeah, and then what could be common?
Common could be coarse facial features can be common, sir. Coarsening of the facial features.
There is a difference, no? Macroglycia can be commonly seen both in acromegaly and hypothyroidism, isn't it?
Yes, sir. Yes, sir.
Yeah. And what will happen to the eyebrows and eyelashes in hypothyroidism?
Loss of eyebrows and
Yeah,
eyelashes,
the hair
especially the
quality in
lateral.
hypothyroidism will be different. Acromegaly will have bone growth, whereas here it won't be.
Yes,
And
sir.
then, as you correctly pointed out, that it is an active disease. So,
Yes,
what
sir.
are the things that tell you that this is an active disease?
Sir, headache, oily skin, excessive sweating, and progressive joint pain, sir, arthralgias. In this particular patient, these four are the features, sir.
And what makes you conclude on hypogonadism?
Sir, actually, I'm not sure of hypogonadism, sir, because for a 48-year female, it could be a perimenopausal status, oligomenorrhea, or it could be hypogonadism secondary to acromegaly. Both can be possible, sir.
See, when you use words in your differential diagnosis, you have to be quite careful,
Yes, sir.
because I mean, you first of all, you need to define what is a hypogonadism. Does it fit in the definition? And then why have you came to this particular conclusion of hypogonadism? Because you mentioned points like no hot flushes. I mean, use your terms carefully. Maybe you wanted to make a point that which all axes are affected and wanted to convince us that, okay, these all are
Yes.
the axes that are affected.
Yes, sir.
And maybe that is what Dr. KV sir and Dr. Jabbar sir. KV sir is around us.
Ramesh sir, you continue, sir, please.
Okay, okay. I mean, I am supposed to take all the ragging today. Okay, okay. Maybe you can proceed, Dr. Manohar. Yeah.
Yes, yes, sir.
How much time exactly we should be winding this up?
It's
Maybe-
9:30 p.m. I
Maybe
think, sir.
we have enough time, sir.
9 o'clock. Chalo, ठीक है. At least, yeah, yeah. So that is the speed that I will keep in mind. Yeah.
Yes. On general examination, patient is conscious, coherent, and cooperative. Her height is 162 centimeters and weight is 64 kgs, and BMI is 24.3, overweight category. She is afebrile. She has a blood pressure of 130 by 80 millimeters of mercury measured in right arm supine position, and there is no postural drop. Her pulse rate is 90 beats per minute, regular, and there is no postural variation. Respiratory rate is 14 cycles per minute and regular, and there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Coming to head-to-toe examination, there is prominent supraorbital ridges, nasolabial folds with enlarged jaw with increased interdental spaces. Macroglossia is there with scalloped margins. There is a broad nose, enlarged lips, deep voice, acne, seborrhea, acanthosis, skin tags, grade 1B goiter, moist palms and thickened skin in the palms. There is no evidence of any acral enlargement, loss of thenar or hypothenar eminence, scoliosis, spontaneous or expressive galactorrhea.
Okay. So you did not check the waist circumference.
Uh, yeah, sorry. Yes, sir. Yes, sir. I didn't check, sir.
What is the significance of checking waist circumference?
Uh, Usually, insulin resistance, if it is more abdominal circumference, could be more, sir.
Mm-hmm. So what is the significance here? Insulin resistance is there, no?
Yes, sir. Yes, sir. Acanthosis
Okay.
and skin tags are there. Yes, sir.
Then you expect the waist circumference to be more or waist circumference to be less?
Usually less in acromegaly patients, sir, because in acromegaly, insulin resistance is associated with less fat mass when compared to other conditions like type 2 diabetes or Cushing's.
Yeah, it is the GH action at the abdominal fat is
Yes, sir.
lipolytic.
Yes,
And
sir. Yes.
so that is one situation where probably you will see a waist circumference that is not as typical insulin resistance. Why is this important to know?
Uh, because Usually, cardiometabolic risk is we can comment on cardiometabolic risk factors.
Isn't
there
insulin
is-
resistance a differential of acromegaly?
Yes, sir. Pseudoacromegaly can be there. Yes, sir.
Exactly. So one of the differentiating points can be your waist circumference, right?
Yes, sir. Yes, sir. Yes, sir.
What do you expect in the pulse in this particular patient?
Usually, if any patient is having arrhythmias, you can expect irregular pulse, sir.
Mm-hmm.
And also, sir,
हाँ बोलो.
and also patient is having hypertension, the high volume pulse can be seen, or
High volume pulse won't be seen, no? Then what will be seen
yes,
in your blood pressure?
usually systolic and diastolic hypertension both can be seen. And if it is tachycardia is there, we can think of thyrotoxicosis.
Okay.
Or even
is,
secondary, sir.
Yeah, fair enough. Fair enough. You told me about a grade 1B goiter.
Yes, sir.
So, yeah. Do you, I mean, you have not described the goiter over here. Have you described it in the endocrine system examination?
No, sir. Usually it was soft and with smooth margins and no thrill or bruise, sir. And diffuse goiter
Usually it is a
there, sir.
diffuse goiter or a
Diffuse goiter.
multinodular goiter?
Multinodular goiter, sir. Usually it is diffuse, but if any single thyroid nodule is there, then we have to think of malignancy as such. Usually it is multinodular goiter.
Okay, so you told me about multinodular goiter, then you said that nodule you would like to rule out um, malignancy. So,
Yes.
I mean, I mean, will you want to reframe it? It is a diffuse goiter or a multinodular one?
Multinodular goiter, sir.
Okay, and why does goiter occur in acromegaly?
It is due to the direct effect of the growth hormone and IGF-1 on the thyroid follicular cells, sir.
Mm-hmm. Okay,
And also if there is a
I mean, do you?
McCune-Albright syndrome, sir,
Mm-hmm. Mm-hmm.
that
Okay,
can be there,
fair
and
enough.
all if there is, sir.
Yeah, fair enough. Fair enough. No problem. Don't get scared. Why a deep voice did you mention?
Usually laryngeal hypertrophy and sinus hypertrophy can cause deep sonorous voice, and also with macroglossia,
Mm-hmm.
which are due to direct effect on the growth by IGF-1 in acromegaly.
Fair. I think any other questions from Dr. KAV sir or Dr. Jabbar sir?
Yeah, we are listening to things and things are going in a very usual manner. And, let's proceed.
Okay, okay, fine, sir. Thank you. Yeah. Yeah, Dr. Manohar, please go ahead.
Coming to systemic examination, cardiovascular system, her JVP is normal and heart sounds were normally heard, and apex beat is also normal and there is no murmurs. Respiratory system, trachea is in midline and with normal chest expansion, with normal vesicular breath sounds and no added sounds. Stop bank questionnaire, it came as for intermediate risk for obstructive sleep apnea. And parabdominal is soft, there is no organomegaly, and bowel sounds were normally heard, and there's no renal bruit. Coming to central nervous system, higher mental function is normal, cranial nerves were normal, visual fields were normal, and fundus examination is within normal limits. sensory examination, motor and cerebellum gait were normal, and cranium and spine, there is no abnormality. There is no scoliosis or kyphosis.
What do you expect in the fundus examination?
Usually, if there is a raised ICT, then we can see papilledema, and also diabetic and hypertensive retinopathy changes can be seen.
Yeah, you can see
And
with almost negligible or minimal diabetes, you can still see the retinopathy changes.
yes,
Yeah, fair. Yes. Yeah, you can proceed. Yeah.
yes. So, come to diagnosis, is a 45-year female with overweight with acromegaly, active disease, probably secondary to pituitary macroadenoma with oligomenorrhea, possibility of perimenopausal status or hypogonadism with obstructive sleep apnea, known hypertensive from 7 years, controlled with medication, and grade 1B goiter with no raised ICT, no compressive features, and no feature suggestive of hypothyroidism or adrenal insufficiency.
What was the BMI of the patient? 24, you said, no?
24, yes, sir, 24.1.
Okay,
Yes, sir.
that's a little, I mean, Indian standards overweight.
Yes, yes, sir. Yes, sir.
Will you call it as acromegaly or a GH excess state?
GH excess state, sir.
Better terminology, no?
Yes, sir. Yes, sir.
How did you conclude that this is a pituitary macroadenoma?
As it is the most common cause, going with the commonality, I have labeled it as pituitary macroadenoma, sir.
Can you say like that?
Sir, in this particular patient, there is no like no
Can your
features of
headache substantiate that this could be macroadenoma?
no, sir. Headache can also be present in microadenoma also.
So why will microadenoma cause a headache?
Sir, even with the microadenoma, there is rise in the intracellular pressure, dural stretch, periosteal thickening, and also release of putative analgesics from the adenoma, which can cause the headache, sir.
Okay. And can your sleep apnea cause headache?
Yes, sir. CO2 retention, and it can cause a headache, sir.
Okay. And yeah, no raised ICT, compressive features, no features suggestive of hypothyroidism and adrenal insufficiency. Okay. ठीक है. Any comments from Dr. Jabbar sir or Dr. Subramaniam sir?
I think it's okay. But I
Yeah.
think as far as pituitary macroadenoma, we cannot say, especially in the absence of visual symptoms and
Yes, yes, sir.
other things. And of course, DA is not there, no diabetes insipidus.
Yes, sir. No, sir. No, sir.
No evidence of zero. And in that case, it's very difficult to legally say there is a pituitary macroadenoma.
Yes, yes, sir.
Headache, as you said, would not suggest macroadenoma only, though it's the most common thing.
Yes, sir.
Any suggestion of any apoplexy in the history or examination?
No, sir.
That should be very important as far as because as Sir said, it is a growth hormone excess state, and it seems active also,
Yes, yes, sir.
but without any visual symptoms. But you said something regarding the eye, something regarding the.
No, sir. Fundus examination is normal, sir.
Is there any proptosis?
No, no, sir.
But when you show the pictures, I think the eyeball seems to be slightly prominent. No? Okay. So you covered them, so I could not say. Okay, right. Okay, please proceed. Please proceed, sir.
Sir, yes, sir. Coming to the investigations, our hemoglobin is 10.8 grams per deciliter with total count and platelet count in the normal range. Our HbA1c is 5.9% with fasting plasma glucose of 98 and postprandial plasma glucose of 108 milligram per deciliter. Our serum creatinine is 1.1 milligram per deciliter, corresponding to eGFR of 72 ml per minute. Blood urea and serum bilirubin, SGOT, SGPT, ALP are well within the normal range. Electrolytes were within normal range with sodium 140 millimole per liter, with potassium 4.4 millimole per liter. Corrected serum calcium is 9.8 milligram per deciliter and phosphorus is 4.5 milligram per deciliter. Her total cholesterol is 152 milligrams per deciliter, triglycerides 259 milligrams per deciliter, LDL 68 milligrams per deciliter, HDL 42 milligram per deciliter, and VLDL of 34 milligram per deciliter. Her TSH is 1.5 micro international units per ml with free T4 of 0.9 nanogram per deciliter. Her prolactin is 18.3 nanogram per ml, FSH 26 milli international units per ml, and LH of 22 milli international units per ml. Estradiol is 28 picogram per ml. Basal serum cortisol is 18 microgram per deciliter. Her IGF-1 is 597 nanogram per ml, well above the normal range for her age. And on GTT, her growth hormone in the first hour it is 6.5 nanogram per ml, and second hour it is 12.6 nanogram per ml, not suppressed. Imaging ultrasound abdomen was well within normal limits. In the ultrasound neck, there is multinodular goiter. On 2D echo, she has concentric left ventricular hypertrophy with good left ventricular and right ventricular function.
Yeah. So why does she have anemia? Because she's not having menses, no, since last 4
Yeah.
to 6 months.
Yes, sir.
Yeah.
Usually in patients with acromegaly, anemia is uncommon, sir. Whenever there is anemia, we have to think of any colonic polyps with bleeding or even peptic ulcer disease and iron deficiency anemia, and also other like malignancies, malabsorption, all these things we have to consider, sir.
Why is anemia uncommon in acromegaly?
Usually, growth hormone has a permissive action on the erythropoiesis, sir. So, in growth hormone excess state, there is increased erythropoiesis.
Mhm. And I mean, in her case, we are getting a low hemoglobin, in fact.
Yes, sir. Yes, sir.
Yeah. So, what will be the evaluation that you will do for her?
Usually, I'll first start with hemogram with peripheral smear to look at the type of anemia, whether it is microcytic or
ಅಂದ್ರೆ ಅದು ವರ್ಕ್
normocytic,
ಮಾಡ್ತಿದ್ದಾನೆ ಗಣೇಶನ್ ಕ್ಲೇ ಕೊಟ್ರೆ ಆಗ್ತಿಲ್ಲೇನೆ
whether it is microcytic or normocytic or macrocytic anemia. With that, I'll approach the causes, sir.
Yeah, I mean, more often than not, you will be thinking in terms of ruling out a malignancy, no?
Yes, sir.
Or
Malignancy, sir.
polyp or something.
Yes, sir. And also, I'd like to go for a colonoscopy and endoscopy in this particular patient. Sir.
Any other relevant thing that you can think of other than colonic malignancy?
Sir, peptic ulcer disease,
Due to?
especially in syndromic causes like multiple endocrine neoplasia.
Yeah, exactly. I mean, when you see that the person is having hyperacidity and
Yes.
anemia and acromegaly, you will definitely want to rule out.
The Zollinger-Ellison syndrome,
Yeah,
multiple
exactly.
endocrine neoplasias. Yes.
Then even in primary hyperparathyroidism associated with acromegaly, you can get excess
acidity, correct?
Yes, yes, sir. Hypercalcemia will cause, yes, sir.
Yeah. Then any comments about the IGF-1 level?
Uh, it is 597 nanogram per ml, sir. Usually, if it is more than 1.3 times upper limit of normal, it is suggestive of growth hormone excess. And if it is more than 2 times the upper limit of normal at the diagnosis, it could be a predictor for mortality even after. Yes, sir. It is predictor for mortality.
Okay. So how much is the level higher in her case?
It is almost 2.5 times the upper limit of normal, sir. This lab reference range.
Okay. And then you didn't do a baseline GH, you did a 1 hour and 2 hour post glucose GH.
Yes, sir.
At
Usually,
times, I mean, uh, when does a random GH also carry a value in acromegaly?
usually if it is more than 10 nanogram per ml, uh, it,
Is it 10 or you would want to?
40, more than 40 nanogram per ml, it has a prognostic value, sir.
Yeah. Also, I mean, if it is above 40, will you still do a post glucose growth hormone?
No, sir. No, sir. The suppression test is not needed. GTT is not needed. If there is elevated IGF-1 levels with elevated basal growth hormone levels, it is not needed.
Yeah, because usually your pulses do not cross 40 in acromegaly.
Yes, sir. Yes, sir.
Okay. Another thing that I just it just lapsed my mind while putting it is panhypopituitarism is also a cause of anemia in
Uh,
acromegaly.
yes, sir. Hypothyroid and cortisol deficiency both can cause anemia, sir. Yes, sir.
And what will it substantiate on a lighter note just to pull your leg?
Again, panhypopituitarism is a predictor for mortality, and we need to replace the hormones.
Won't it
Preoperate.
substantiate that more often than not you are clinched your diagnosis of macroadenoma? Because if
Yes,
the
sir.
person gets panhypopituitarism,
Yes, sir. Yes, sir.
that's usually due to macroadenoma,
Yes,
right?
yes, sir. Yes, sir. Yes, sir.
Yeah, fair enough. Any other comments from Dr. Jabbar sir, Dr. Subramaniam sir?
I think we can proceed. Yeah.
Yeah, I think
Okay, proceed.
Next, we have proceeded with the imaging, sir. MRI cellular contrast with dynamic imaging. It has shown partial empty cellular and a cyst of around 2.2 millimeters in the pituitary gland with mucosal thickening in the right sphenoid sinus and incidental Thornwald cyst. This is the sagittal T1 image, sir, which
yeah,
is showing a partial empty cellular. And even with
correct.
contrast, there is partial empty cellular. The stalk is visible, and there is a small cyst in the pituitary, sir, in the posterior aspect.
Okay, fair enough. Yeah,
And these are also the coronal view, sir, which is
yes,
showing no mass or focal pituitary lesion.
yeah. So
Uh,
where are we standing now?
uh, Now we have a biochemically active disease with negative cellular imaging, sir.
Mhm. So why can this happen?
Uh, sir, these are the possibilities, sir. It could be pituitary apoplexy where micro or macroadenoma undergo infarction or hemorrhage, and still there could be persistent growth hormone hypersecretion from the residual cells. But there could be history of sudden headache and associated other hormonal changes, or it
Mhm.
could be an ectopic pituitary adenoma, which are the rare adenomas arising from embryonic pituitary remnants outside the cella, as in sphenoid sinus, nasopharynx, or the suprasellar region. It could be an ectopic growth hormone releasing hormone secreting tumor, sir. But usually they cause pituitary hyperplasia. Presenting as partial empty cell is rare, so I put this as a differential down the order, and could be imaging limitations, especially in case of microadenomas. But again, going on with the incidence and macroadenoma is common in acromegaly. These are
See, it is
the
not that macroadenomas are exactly common in acromegaly. There are reports of even microadenomas, and there
yes,
are
sir.
even
Yes, sir. 20.
published papers which have shown that the conventional MRI imaging did not identify the
Yes, sir.
adenoma.
Yes, sir.
So,
Yes, sir.
what will you do in that case?
Sir, in situations like those, first thing is if we are still considering a microadenoma, we can go for volume interpolated 3D gradient echo.
See, other than this volume interpolated 3D gradient echo, something that you are routinely doing, what are you doing? How are you ordering a pituitary MRI as such?
Slice thickness, reducing the slice thickness, sir.
Mhm.
Usually from
So,
2 millimeters to 1.2 millimeters will help.
something more that you can be doing?
3 Tesla MRI we can use, sir.
Dynamic contrast?
Yes, sir. Dynamic. Yes, sir. This is a dynamic contrast imaging, sir.
Yeah, that's what I mean. Dynamic contrast is there, but then the image that you have showed is not of a dynamic contrast sequence as such, no?
Yes, sir. But
Yeah.
for the reference, I put these 4 slides only, sir.
Fair enough. I mean, I'm not disagreeing. I'm just telling you that what you put in is a good quality MRI. What you could have maybe told is that we have already done a dynamic contrast MRI.
Yes,
Fair
yes,
enough.
sir.
That's
sir.
what I wanted to know. That you should be doing a dynamic contrast MRI, not
Sequence,
always
yes, sir.
considering this as a it can also be a microadenoma causing this. Okay.
Acromegaly, yes, sir.
Acromegaly, correct.
Yes, sir.
Yeah,
Uh,
fair.
Usually in the evaluation of such cases, whenever there is an empty cella, we have to look for ectopic source. We have to measure the growth hormone releasing hormone and CT of the chest, abdomen, and pelvis. And gallium dotatate PET CT also is useful, sir, to identify the source. In this and apart from this, we can use this wipe sequence, which gives higher resolution, as you can see here in the images. And it is mainly useful in the Cushing's disease to diagnose the microadenomas, not much studied in acromegaly and microadenomas. And somatostatin receptor PET imaging is also highly sensitive for tumors expressing the somatostatin receptor. We have the gallium dotatate, gallium dotanoc, and gallium dotatoc, of which dotatoc is preferred due to its affinity for somatostatin receptors type 2 and also for type 5, whereas dotatate has lower affinity for somatostatin receptors type 5. And in this particular patient, we could not do growth hormone releasing hormone levels as due to the high price, sir. And also we did CECT of chest and abdomen to localize any ectopic growth hormone tumors, but in this patient, it came out to be normal study, sir. There is no evidence of any masses.
Okay, so you did CECT chest and abdomen, and then you did a somatostatin receptor PET
Yes, sir.
imaging, gallium
Yes.
dotatate. So what did
Yes,
your
sir. Yes.
gallium dotatox show?
Yes.
Yeah.
Yes, sir. It showed a somatostatin receptor expressing soft tissue along the floor and lateral wall of the sella turcica, and also a tissue of around 1.4, 1.1 into 1.9 centimeters with mild erosion of the posterior wall of the right sphenoid sinus, sir, which is suggestive of ectopic pituitary adenoma.
So how do you conclude that this is an ectopic pituitary adenoma?
It is arising in the right sphenoid sinus.
there is a erosion of the wall, no?
Yes, sir.
So
Two
can't
causes.
it be an expansion of the pituitary cells there and causing it?
Yes, sir. Yes, sir. That is also possible, sir. Invasion of the tumor seeping into the sinus is also possibility, sir. Yes, sir.
Yeah, because I mean, we also had a similar case, and I mean, to call it as a ectopic pituitary adenoma, you need to show a total maintenance of the bone windows, correct?
Yes, sir. Yes, sir.
So did you do a CT with bone windows?
No, sir. No, sir. We didn't do, sir.
Okay, your neurosurgeon was not keen on that, or ENT surgeon did the needful.
Yes, yes, sir. Could be. Usually for TSS,
Okay, fair enough.
for patient undergoing TSS, we'll do the bone window, sir, to look at the sinus patency and everything.
Yeah, here the tumor is in the sinus.
Yes, yes, sir.
But at least
Yes,
for
sir.
an academic interest, you could have done, because that makes your case stronger, no? Anywhere you have to
Yes,
put
sir.
this up for presentation, you can always
Yes,
show
yes.
that, okay, we have done bone windows. Just for your knowledge, but I mean, one center in our vicinity uses nota octreotide,
Yes, yes, sir.
F18 nota. I mean, that is one alternative. Though,
Yes, sir.
I mean, you are correct in saying that probably gallium dotatate is the better. Yeah. Anyways, good. Yeah. Next.
Sir, in the management of this patient, actually, we have took a neurosurgery consult and an ENT surgeon consult, and they decided to do it together, sir. But the patient, due to her personal restraint, uh, didn't went for surgery and said she'll go for another after 3 months.
Another.
After 3 months, she said she'll undergo the surgery, sir. So,
Fair enough.
yes, sir. Further management was not done in this patient.
Mhm.
So, uh, coming to a discussion point, sir, despite the classical biochemical and clinical features of acromegaly, MRA showed partial empty cella with no definite pituitary lesion. However, a gallium dotatate PET-CT revealed somatostatin receptor expressing lesion in the right sphenoid sinus, could be suggestive of ectopic adenoma or invasive misplaced adenoma. And also, it could represent an invasive adenoma with extracellular extension not visible on conventional MRI, as you have rightly mentioned, sir.
Yeah.
In management strategies, transnasal endoscopic resection of the tissue in the sphenoid sinus and exploration scraping of the cella is required in this patient with joint management of ENT surgeon and a neurosurgeon. And medical management can also be used in this patient with long-acting somatostatin analogs like octreotide, LAR or lanreotide, pegosamant or paltusotine. Even though it is not available, paltusotine. Radiotherapy, it must be considered cautiously in this patient due to the atypical tumor location and proximity to the critical structures. So,
Radiotherapy, why it should be used cautiously, and which
sir,
critical structures are in the proximity to this tumor?
Sir, as this tissue is extending from the sinus to the cella, more field of radiation might be required, sir.
Not, uh, not really. No, I mean, you see much larger tumors which have already covered a lot of area in
Yes, sir.
acromegalies, right?
Yes, sir. Yes, sir.
Yeah. Radiotherapy is not going to be your first line of management.
Yes, 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 sir.
No,
Yeah.
probably what Manohar wants to tell is because behind is the brainstem.
Yeah.
So probably that will be affected if both of the modes of radiotherapy are employed.
Okay.
That's what you mean, probably.
Yeah.
Please, please.
And will you consider medical management in her?
Yes, sir.
since
Yes,
the
sir.
patient does not want a surgery for now?
Yes, sir.
What
We
will be the
prefer,
pros and cons of medical management?
uh, sir, pros, definitely, it will reduce the uh, biochemical, it will improve the biochemical picture, and also patient is having obstructive sleep apnea. So, preoperative management with SRLs is uh, best, and also the cons is mainly the pricing, sir. It is usually very costly.
So what happens to the tumor after you start this?
Uh, we can see a slight shrinking of the tumor, sir.
I mean, can you quantify that for me?
Around almost 50% shrinkage can be observed with medical therapy alone, sir.
Is it, or will you like to change the number?
Uh,
Anyways,
so,
all said and done, say at least 2/3 chances that there will be some degree of shrinkage.
yes, sir. Yes, sir.
But then any other issues like that you anticipate?
As in side effects, sir. Uh,
Not exactly side effects. See, what happens say when you give this is that the tumor becomes more harder and the
yes,
surgeons find it little difficult to handle. So it is always better to operate.
yes, sir.
Earlier, there was a
Yes, sir.
school of thought that okay, you shrink the tumor and then operate. But
Yes, sir. Yes,
operating
sir.
a tumor after the shrinkage caused a lot of fibrosis.
Yes, sir. Yes, sir.
And so the surgery may become a little difficult, not exactly, yeah, but that is what.
Yes, sir.
Yeah. And when will you put radiotherapy in this particular patient?
Uh, uh, so, after surgery, if there is still residual disease and not biochemical control not reached with medical management, then I'll like to go for radiotherapy, sir.
So if there is a resection that is done and still there is a residual disease.
Residual disease, yes, sir.
Okay. So will you consider radiotherapy first or will you consider medical management first?
Medical management, sir.
Why?
With radiotherapy, usually it will take time, and also there is chances of other hormone like hypopituitarism can be seen. Whereas with medical management, almost 60% reduction in 60% of the cases, reduction in IGF-1 will be seen. Whereas with
Can you
radiotherapy,
achieve a cure with medical management or you can achieve a cure with radiotherapy?
uh, with radiotherapy, I think, sir. I'm not sure, sir.
See, radiotherapy will cure your disease, no? Even if it will cure
Yes, sir.
after how many days roughly?
10 years. 10 years.
Yeah.
At the 10 years, disease.
Yeah. But then medical management will not cure your disease, right?
Yes, sir. Yes, sir.
Yes. But then if you give radiotherapy after medical management, the response rates are
Higher, sir.
higher or poorer?
Uh, sir, I'm not sure, sir.
Radiotherapy essentially acts on cells which are multiplying, right?
Yes, sir. Yes, sir.
With the
Uh,
medical management, you are stopping the multiplicity of the cells.
yes, sir. So
So you are in
response
a
will
way
be poor.
desensitizing them to radiotherapy, correct?
Yes, sir. Yes, sir.
So a correct way is that in a practically in our country where lifetime medical management is going to be difficult,
So,
it is always better to radiate and then put them on medical management so that the disease free interval is better. The
yes,
load
sir.
at least starts reducing, and then your medical management you can at least I mean even your dose needed of octreotide can become lesser over a period of time, and you can look at a curative intent.
Yes, sir. Yes, sir.
Yeah. So and which radiotherapy will you prefer?
External beam radiotherapy, sir. IMRD. Yes,
3D conformal radiotherapy,
sir.
no? 3D
Yes, sir.
CRT.
Yes, sir.
Not
3D,
gamma
sir.
knife or cyber knife.
Yes, sir. Yes, sir. Yes, sir.
Which will you prefer?
IMRD only will prefer, sir.
IMRT is a gamma knife.
It, uh,
Conventional
yes, sir.
radiotherapy.
Yes, sir.
3D CRT you are saying about.
Yes, sir.
Why not a gamma knife or a cyber knife single setting?
Usually proximity to optic chiasma, usually if it is there less than 5 millimeters, then it can cause damage to optic chiasma. So
Yeah. And in this case, the optic chiasma is nowhere near to the tumor.
yes, sir. Yes, sir. And usually if size is less than 3 centimeters, we can use that, sir.
Okay. The ease is with 3D CRT, but you can selectively consider even gamma knife.
Yes, sir.
Okay. Any complications of medical management of acromegaly?
Yes, sir. Side effects mainly include the gastrointestinal side effects, and also gallbladder sludge can be seen. And in some cases, bradycardia, hypothyroidism can also be seen, sir. And also
Which
there
is
is
an important complication of medical management.
hyperglycemia is also.
Exactly.
Yes, sir.
Dysglycemias are common.
Yes, sir.
Yeah. Any comments from Dr. KV, sir? I think we have little exceeded the time, but Ramon can agree. Pardon us for that.
No, this is a very interesting discussion you are doing, and we really enjoy it. The only thing is, when the cell size is not small.
Yeah.
So when the cell size is, there is empty cell, but cell size is not small. If it were to be small, then we would have thought of ectopic as the first possibility. Cell size
Yeah.
being normal means probably there is a pituitary inside the cell previously. And there is herniation of the optic chiasma that also says that probably this is a recent happening. And definitely the cause for this would have been apoplexy, or as Amaya said, there is erosion of the floor of the cella and herniation of the pituitary into the sphenoid sinus. And would be making the job easier for both neurosurgeon as well as the ENT surgeon. So it has dropped down. And I think there is a suggestion of erosion also. As Dr. Amaya suggested, probably a CT scan would have told us whether the floor of the cella there is a gap,
Yes, sir.
there's an erosion, and that would have been helped us in looking at it. And if the cell size were to be small, then I would have thought of congenital empty cella with ectopic pituitary. Probably that would have been the first one. But here I think because the cell size is almost normal, not or slightly more also. So probably that's why I thought it is in a drop-down pituitary rather than this one. And there are no other hormone abnormalities except that doubtful hypothyroidism, secondary hypothyroidism. You can see the free T4 is 0.9, lower limit of normal or below, and TS6 is 1.5. So it could be a secondary hypothyroidism, but okay, that is a normal thing, whether it is a whatever it is. And other things are not there, so probably other cells are not affected. So probably both are living together without any bad effect on the other things. And probably at the history of apoplexy, that's what I wanted. So that would have been with the cause for Epicella. Probably if there is an herniation or erosion and the pituitary has dropped down, naturally the cella would be empty cella may be there. Probably these are my views, and my are probably.
No, sir. Very, very well taken point. That's what we were just pulling his leg. He should have came out with this. We could have given him a gold medal.
Yes. You're right, exactly. Yes. The things. I think we can request comments from Dr. Dilip or Dr. I think Jaya is there. Alok is there. Srinivasidu. Anybody wanted to make a comment? Vamsi? I think I've seen Madhu also. Jaydev? Any comment is there?
Yeah, I think it is always a very difficult one, sir. Whenever you don't find a tumor with a actively functioning pituitary problem, trying to locate it is going to be a problem, and medical therapy is definitely a good option. They are very well available and good source of reducing the growth hormone levels and the disease burden. Interesting case, especially given all the clinical problems that the lady has.
And any more comments?
You can get a reasonably good medical control with the agents which are currently available.
Yeah.
Only the cost is the problem.
Resident from,
Please.
yes, sir. Second year resident from Mangalore, sir. So small doubt. This because I probably don't remember. Dotted it is done, no, sir. Like because because already we know the SSTR expression. Can we choose the medical therapy based on the scan, octotide or?
There's always a choice.
Question. Because here that scan is done. Otherwise, we may not know. Based on the scan, can we decide? Based before pre-operatively, because we'll be knowing only based on histopathology what SSTR expression we have to keep the treatment. But here already scan is done. Based on that, can we choose the treatment?
Definitely that will help. Definitely that will help in choosing the treatment, medical treatment, octotide.
So in future, like this scan may be useful for maybe most of the patients.
Because this is a PET scan where we are looking at the these particular receptors. But the only thing is it won't tell us about the presence and absence of other receptors. See, this is only one receptor what we are expecting with this SSTR5. But see, they don't tell us about the other receptors, whether they are present or not. But definitely this will guide because see, most of the octotide and other things, paclitaxel, we know one is predominant and it will add to the other also, other SST also. So naturally that can be also thought of. Any comment from Amir, please?
No, sir. I think if the uptake is very high, that can predict that the response will be good. Then it indicates that the density of SSTR2 is pretty high.
Yes. There is a definitely will guide it, as you said.
Thank you.
Good. Thank you for question. Thank you for the question. Any more? If no more, I think I request Vivek to. Vivek, Ramohan, you wanted to say something?
Thanks a lot, Amir sir, for a wonderful insight, sir. Thank you, Subramanian sir. Thank you all the faculty, and thank you all the delegates who attended this webinar. Thank you, Manohar, for a wonderful case presentation. Thank you.
And thank you from my side also to team ESAP for giving me this wonderful opportunity. My best wishes to all the residents who have joined. God bless all of you.
But this is a wonderful discussion by Amaya. Actually, this is wonderful. Thank you. Thank you very
sir.
much. And good
Whatever
night.
little I could add. My pleasure.
Good night. Good night.
Good night, sir.
Namaste. Thank you.